Kia ora koutou, and welcome to tonight's Goodfellow Unit Webinar on HPV primary screening for cervical cancer. For this webinar, the Whatu Ora Te Toka Tūmai Auckland and Waikamatā have invited the National Cervical Screening Program, NCSP, to provide an update prior to the rollout on the 26th of July. My name is Dr. Courtney White, and tonight we'll hear from a panel of speakers. Rachel Mackay, General Manager of HPV Implementation and Innovation, Alicia Blaikie, GP and Primary Care Advisor at HPV Primary Screening Implementation, Margaret Stage, NCSP Clinical Lead Pathology and Laboratories, Liz Pringle, Cytoscientist, and Paul Spek, Charge Scientist of Cytology. So I will now hand over to our first speaker, Rachel. Thank you, Rachel.
Thank you, Courtney. Thank you for the opportunity to meet with you this evening to give an update on the transition to HPV primary screening. It's an absolute pleasure to be here. And a special thank you to the Northern Regional team for supporting this Auckland and Northern Screen Takers workshop, and a very warm welcome to everyone else from around the motu. We've got three presenters from the screening team here this evening. I will talk about how Te Whatu Ora are approaching the rollout to HPV primary screening, and I'll be covering the first half a dozen bullet points on the slide. Alicia will talk about what the changes mean for clinicians, and Margaret will talk about what the changes mean for laboratories. We're also very fortunate to be joined this evening by two speakers from the laboratories. We have Liz Pringle from APS and Paul Spek from Aotearoa, formerly known as SCL. To meet the World Health Organization goal of eliminating cervical cancer, we need to improve vaccination and screening rates. HPV screening is the gold standard in cervical screening and will provide opportunities to gain equity, and the move to HPV testing is expected to make a significant difference. As this slide shows, the number of Māori and Pacific Island participants has been dropping since around about 2018. We're optimistic that because the new test is less invasive, we will see an increase in participation in these two groups in particular. Vaccination is a vital part of the overall strategy. It's able to be accessed by everyone in years 7 and 8 at schools participating in the school-based program and through primary care as well. The vaccine is funded for everyone aged 9 to 26 years. It's also licensed for use up to 45 years. So both males and females aged 27 to 45 can access the vaccine. However, it's not funded for this age group. Participants who have been vaccinated will still need screening, as not all HPV types are covered by the vaccine. HPV primary screening is part of the National Cervical Screening Program, which is not a fully funded program. We know funding's a challenge, and this is something we're asked about quite often. Most participants will still need to pay a co-payment, and it is up to providers to set the amount of that co-payment. We acknowledge that the test is changing, and this learning phase, additional time may be needed to get familiar with the new test. However, over time, it should be less demanding. And support to screen services will continue to be available. We are continuing to work and looking for ways to reduce cost barriers with a focus on Wahine Māori and Pacific women with high risk of cervical cancer, and for free surveillance and follow-up. Just as one example, funding of $35 million was recently announced in the 2023 budget, and that will be used to improve immunisation and screening rates for Māori and Pacific. Now, this is quite a busy slide, so I'll take a wee bit of time to work through it. Our vision is to reach more participants in their own communities. We're prioritising equity by having new pathways that empower participants with choice, and the aim is to increase participation in Māori and Pacific people through proactive communication and support. As I've mentioned, the HPV test is less invasive, which is anticipated to help achieve equity for Wahine Māori and Pacific communities. HPV Primary Screening Project will support new clinical pathways that will provide greater choice to participants to lift uptake, increase screening in our priority groups, and reduce mortality rates in our communities. HPV is the primary screening test. It will find more precancers and prevent more cases of cervical cancer, supported by cytology and colposcopy. The new National Cervical Screening Program register will be the single source of information for screening records and individual schedules. The register is different than the current register in that it's population-based using NHI data. And this allows us to reach those people who are eligible for screening, but who are not enrolled in primary care or currently accessing cervical screening through family planning or support to screen providers. New pathways embed more choice and flexibility, removing barriers to entry and better support and increase equitable outcomes for Māori and Pacific people. And additional workforce and training. Accredited screen takers, GPs and midwives will be able to do HPV testing as well as cytology testing. We're also keen to grow other roles in the workforce, much like was done during COVID-19, with roles such as Kaifina to support the new test. HPV primary screening is being implemented in a phased approach to support a safe and managed rollout of the program. We will only go live on the 26th of July if it's clinically safe to do so. The 3 phases outlined in the lower part of the slide cover the phased approach. The first phase is the foundation step from the 26th of July, and that's effectively the launch. That's when we turn the lights on. And at that stage, all participants will be able to choose a self or clinician-supervised HPV primary screening test or a cytology test, and screen takers will have undertaken the training, which I will cover in a couple of slides. For primary care, at that foundation stage, there's no change in terms of how you access information. Please continue to use the 0800 line as you do currently. Phase 2 is through the rest of this calendar year, from August through to December. And at that phase, we'll be building on the basics by widening the participant base and increasing uptake. There'll be a strong priority focus on Māori and Pacific and unenrolled in primary care and underscreened. Primary care now has the ability to easily access screening history during this phase, and we're working with your PMS vendors, which I'll cover shortly too. And phase 3 is January to March next year. And that's really when we embed this as part of business as usual. And it's about achieving the future state and moving into continuous improvement. One thing I do want to point out is there is no centralised mail out currently planned for HPV primary screening. So that's different than bowel screening. So we will not be undertaking mass mail outs of the screening test. I mentioned that we're working with the practice management system vendors. There are 4 PMS vendors who need to make changes to accommodate the change to HPV primary screening. And these changes are about updating the lab request form, changing the screening period from 3 to 5 years, recording the results of the HPV test. Now, how this will look varies from vendor to vendor. Some attach a flat file and others will record the results and recommendation in specific fields. We are working with the vendors to ensure that they'll be ready to deploy the changes prior to the 26th of July, including providing user documentation. You will be supported through this change with training and support. There will be 4 separate training modules on Learn Online that we recommend screen takers complete. Training for the register and provider portal will be offered to those who need it. And we will have information packs and drop-in sessions as well. We have several resources available on our website, including a video and the clinical practice guidelines and other supporting material. Now, these are the key dates. Clinical guidelines and the video providing an overview about HPV primary screening are available now on the website, and more information is being added to the website over the coming months. The e-learning modules are scheduled to be available around mid-June. In early July, primary care will be able to order HPV test consumables from Laboratories, and you'll be able to view, download and order resources from Health Ed from around mid-July. The public campaigns start from mid-July with a particular focus on Māori, Pacific and under or unscreened populations. As I've already touched on, the Go Live Foundation date is the 26th of July, and that's when the lights get turned on, and the HPV test becomes a primary screening test for cervical cancer. At that stage, the new register will be in use, and those people who currently have access to the register, such as regional coordination teams, will have access to the new register. If you don't have access to the register now and you need information about screening history, you'll continue to use the 0800 number as usual. Colposcopy clinics will be ready to manage additional workloads, and they would have been upgraded to Gynae Plus version 11, and laboratories will be ready to process HPV tests. You should have finished the training by this date and you'll be able to use the new test. Please note that cytology will remain really important, and you can see at the bottom of this diagram there will be ongoing training and support throughout the coming months. Thank you for your time, and over to you, Alicia.
So I just wanted to start off with a brief overview of sort of a little refresher on human papillomavirus. So there are over 200 types of HPV, and around 40 of these can affect the genital region. It's transmitted by intimate skin-to-skin contact, so that includes oral, vaginal, and anal sex, as well as intimate touching and sharing of sex toys. Genital HPV is very common, so 80% of people will have HPV at some stage of their lives, and most infections occur soon after the beginning of sexual activity. The vast majority of these infections clear up themselves, so 90% of people will clear the infection within 2 years. There are 14 high-risk types or oncogenic types of HPV, and it is a persistent infection with one of these high-risk types that is the cause of over 95% of cervical cancers. And it's these 14 types that we test for in the HPV test. So the HPV is a better primary screening test. It's a PCR test, and it's a much more sensitive first test than the cytology test. So using HPV as the primary screening test will detect around 95% of people with high-grade cervical changes. Using cytology as a primary screening test will detect around 80% of high-grade changes at the very most. HPV testing is not a specific test, so many people who have HPV detected will not have any cell changes. So anyone who has HPV detected needs to go on to have further investigation with cytology or colposcopy, depending on the type of HPV that's detected. The next great thing about the HPV test is the very low risk of having high-grade changes in the cervix for at least 5 years after an HPV not detected result. This graph compares the incidence of CIN3+ after normal cytology and an HPV not detected result at time 0. So the cytology is shown in that sort of bluey purple line, and the HPV not detected result is in the red line. So if you go out to 36 months and go up to the purple line, then that's the incidence of CIN3+ 3 years after a normal cytology test. And if you go out to 60 months and up to the red line, that's the incidence of CIN3+ 5 years after an HPV not detected test. So you can see that you're in a better position 5 years after an HPV not detected test than you are 3 years after a normal cytology test. So this allows us to safely extend the screening interval for 5 years. And we can reassure people that the chance of developing high-grade cell changes after an HPV detected test result is really low for at least 5 years. This includes after the first screen, so we no longer need to do that repeat test 12 months after a first screen. Even if someone gets a new HPV infection the day after they've had an HPV not detected test result, that risk remains really low for 5 years. So we don't need to test more frequently for people who are at higher risk of getting HPV, or if someone's had a change of partner. Just to be clear, there's no change to the current recall. So if someone had a cytology test 2 years ago, their next test will be in 1 year's time. We're not going to extend the time from a last cytology test. For people who are immune deficient, their new recall will be 3 years, and they get a referral to colposcopy clinic if any type of HPV is detected. Now, the lab doesn't know if someone's if someone is immune deficient. So it's really important that you write that information on the lab form, because otherwise you're going to get the incorrect recommendation on the bottom of the result. There's no change to the screening eligibility, so it's still for ages 25 to 69 for people who have a cervix, and that's regardless of their gender or the gender of their sexual partner. There does seem to be a little bit of a myth out there that women who are in same-sex relationships don't need cervical screening, but because of the way that HPV is transmitted, this isn't true. Just a note about trans and non-binary people with a cervix. As Rachel mentioned, that new register is NHI based. So if someone is recorded as being male, they are not automatically invited to become on the program. So you can inform the register that someone needs screening either by calling or emailing the register. And the register has the ability to hold sex assigned at birth and gender information. The priority groups for the cervical screening program are based on those with an increased risk of developing cervical cancer. So these are Māori and Pacific peoples and people aged over 30 who are unscreened or underscreened. And also just a reminder that cervical screening is safe in pregnancy. Pregnant people follow the same clinical algorithm as non-pregnant people, but they are treated a bit differently at colposcopy clinic. So biopsies are usually delayed until after delivery unless invasive disease is suspected. But that visit to colposcopy clinic, if it's needed, shouldn't be put off because undetected invasive disease is associated with poorer outcomes for both mums and babies. So now we come to the bit that is exciting for all of us, is the ability to have a self-test. So this is a vaginal swab. People can still also choose to have an LBC test if they prefer. So the same way that we do smear tests. This would first be tested for HPV, and then if HPV is detected, the cytology is automatically performed. Just to be clear, people can't choose to continue to have cytology as their primary test. And if you send in an LBC sample, you don't need to send in a swab as well. It's the same pottle is processed for both HPV and cytology. The cytology can't be performed on a swab sample. So if HPV is detected on a self-test, then that person will need to come back for further investigation. The awesome thing is that the self-test is equally effective as a clinician-taken sample at detecting HPV. So we can reassure people that this is a great option. The HPV swab can only be processed for HPV. So if you're doing an STI screen at the same time, these are done on separate swabs, and it doesn't matter which order you do these swabs in. The HPV swabs are only validated for vaginal use, so they can't be used in the oropharynx or anus. As I said, the self-test is a vaginal swab. There is no need for a person to find their cervix. The swab is inserted 3 to 4 centimetres into the vagina and gently moved around the vaginal walls for 20 to 30 seconds, the same way that people do a self-swab for an STI screen. The swab can be done during someone's period, but if the bleeding's very heavy, it does increase the chance of an invalid test result, which Margaret's going to talk about a little bit about later. The self-test does require informed consent and for a clinician to take responsibility for following up results and arranging any necessary follow-up. There are several research groups who have been offering HPV testing around the country, and they've shown that the option of self-testing has increased the screening rates of under and never screened wahine Māori. Some clinics who have been involved in the HPV research have found that it can be a bit tricky to get the tests back if people take them off-site. So that's just something to consider when you're setting up the processes in your own practices. Some other feedback we've had from the research groups is just how important it is when you're consenting someone that they really understand that if HPV is detected, that they will need to come back for further testing. They have had some people who are a bit annoyed that they've had to come back for a second appointment and pay again for a test that they could have had in the first place. So those just first conversations that you have with people are really important. The HPV self-test is an awesome option for most people, but there are some people who need to have a liquid-based cytology sample. So anyone with abnormal bleeding needs to have visualization of their cervix and a co-test. So that's an HPV test and a cytology test, which is done on the LBC sample. It's really important that you tick both HPV and cytology on the lab form and write that the person has symptoms, because otherwise the lab's going to assume that it's a screening test, and if HPV is not detected, they won't process the cytology. Obviously, any other investigation depends on their clinical situation, but if it's cervical, if you're looking at the cervix as the cause, then you need to do a co-test. The other group that need a liquid-based cytology sample is anyone on the test of cure pathway. So the test of cure used to be done in colposcopy clinic, but is now done in the community. So a test of cure is for those who have had a high-grade squamous cell lesion that's been completely excised in colposcopy clinic, and they need to have a co-test. So again, that's an HPV and cytology done at 6 months and 18 months after their treatment, so 12 months apart. If the cytology and the HPV are negative on both occasions, then they can return to a regular screening interval. There are lots of people who are on annual cytology tests for quite historical high-grade lesions that potentially could have a test of cure and get off that annual recall. There are some people who will need to continue with annual co-testing, and in particular those who have a historical glandular lesion where the HPV status is unknown would need to continue to have annual co-testing. There are some groups who you might be more inclined to recommend an LBC for. So these are people who might have a higher chance of having HPV detected and needing that cytology sample processed. So people have had a previous low-grade result who haven't gone back to a regular screening interval in the current program, or people who are on follow-up after an HPV other result, and I'll talk a bit more about that soon. And just if it's going to be hard for someone to return because they live far away, or they're just busy, or if they just don't want to come back for a second appointment, that might be someone who might prefer to choose an LBC sample as their first test. So we're expecting around 90% of people will have an HPV not detected result, and for most people their next screen will be in 5 years' time. Around 2.5% of people will have HPV 16 or HPV 18 detected, and they get a direct referral to colposcopy clinic. If they haven't had cytology done, if they haven't had an LBC done as their first test, the cytology sample will be taken at colposcopy clinic. The reason that 16 and 18 are treated differently from the other types is that they're responsible for around 70% of squamous cell cervical cancers, and they're more likely to progress and progress more rapidly than HPV other as a group. So the remainder 7.5% of people will have HPV other. So these are the other 12 high-risk HPV types, and they're reported collectively, though some labs may give you a subtype as well. If HPV other is detected, then cytology is needed. Anyone with a high-grade cytology result is referred to colposcopy, just like they are now. If the cytology is normal or low-grade, then these people get a repeat in 12 months' time, and an LBC sample is recommended at that stage. So if HPV is not detected at that 12-month recheck, then the person can return to a 5-yearly screening interval. If HPV other is detected, then the further management depends on the person's age. So if they're 50 or older, then they are referred to colposcopy clinic at that stage. If they are under 50 years old with a normal or low-grade cytology result, then they have another test 12 months later. And if they still have HPV other at their third test, then they're referred to colposcopy. So if at any stage during that time they have HPV 16 or 18 or a high-grade change, they're also referred to colposcopy. The lab result that you'll get in your inbox will have the recommendation of the next step based on the person's result, their age, and their previous cervical screening results. So they will come with recommendations. Something that will come up for you is about HPV and relationships, and that's because if you Google HPV, it starts talking about HPV being an STI. So this test doesn't tell us how long someone has had HPV for. They may have had HPV for many years or even decades without realizing it. And it is possible for HPV to be latent and undetectable by the test, and then to reactivate at a later time. So if someone has an HPV not detected result in July, and then 5 years later has an HPV other detected, it doesn't mean that they have necessarily been infected during that time. And it also this is also the reason that it's really important that people who have an HPV not detected result and are no longer sexually active still continue to test to have their cervical screens, because it is possible that the virus reactivates. So when you're getting to the end of the cervical screening program, everyone needs to have an HPV not detected result before they stop screening. So for those aged 65 who aren't immune deficient, who have an HPV not detected result, they can stop screening because their next test would be due after the age of 70. As mentioned before, those aged 70 to 74 who are unscreened or underscreened should have a negative HPV test before stopping screening as well. People who have had a total hysterectomy with a normal screening history can stop. And for people who have a more complicated history than that, there's at the new clinical guidelines, there's an algorithm that you can follow, or you can call up for advice around that. If you'd like any more information about the transition to HPV screening, there are resources available. There's a monthly sector update, which you can sign up to receive by emailing the HPV screen at health.govt.nz. There's an FAQ page on the NSU website in the health professional section that's being updated currently, and we aim to get the answers to the questions that we're asked at these, and we'll get those updated after this as well. And now I'm going to hand over to Margaret to talk about the laboratories. Thank you, Margaret.
Kia ora tātou. I'm Margaret Sage. I'm the clinical lead for pathology with the NCSP, and I've been working in cervical screening for quite a long time, so you may have come across me before. I'm going to talk about the changes that are coming in laboratories, and then the lead cytoscientist from APS and SCL will talk you through the specifics for those of you who use their respective laboratories. So last year there was a procurement exercise to reduce the number of laboratories in New Zealand who report cytology and HPV, because with the change to HPV testing, there's going to be quite a reduction in the amount of cytology, and there won't be enough work to sustain the current 5 labs. So the 3 labs that are going to continue after July are APS in Auckland, Pathlab in Tauranga, and SCL, who are currently undergoing a name change to Aotearoa Labs in Dunedin. So APS and SCL already operate in the Auckland and Northland region, and those referrer relationships aren't going to change in this area. In the wider North Island, Pathlab are going to be picking up extra work in the central North Island region, so there will be some practices who'll be changing laboratory provider, and that may involve a change in LBC type as well. There are 14 laboratories around the country who report cervical histology, and there's no change to those services. Laboratory staff are really committed to providing you with good clinical support, and there are a number of ways you can help us to do that. Firstly, sending accurate information is always very helpful. There are going to be 2 printable request forms available on the NCSP website for the new program. One will be analogous to the current pink form, and that will you'll be able to order HPV tests or cytology tests or both, or histology as well. That'll cover any type of cervical pathology request. And there will be a simpler one that can be used just for HPV swab samples, because we don't need as much clinical information to report an HPV test. Accurate sample and form labeling is as critical as ever, so that we get the right result to the right person. A qualified sample taker or doctor must sign the request form, because we do need to make sure that the result goes back to a person who knows how to manage the result. There will be others who will be able to assist with self-testing, but they'll need to work under supervision, and there will be further expansion to that workforce as time goes by. Please notify us if there are symptoms or if the cervix looks abnormal. This is no longer screening, and these people need an LBC sample for a co-test. And as Alicia has mentioned, we do need to know why the co-test has been requested, otherwise cytology won't be performed if the HPV result is not detected. If you do write anything on the form about symptoms or an abnormal cervix, the decision about whether to refer somebody with bleeding is a clinical decision. It's not a laboratory decision, but we will include a comment in the report to record that you have noted the presence of symptoms and signs, so that if the results are normal, there will be a line in the report which will remind the person receiving the report that you do have to consider the symptoms in terms of whether you need to refer the person or not. One thing laboratories don't need you to keep doing is providing us detailed NCSP history information. So we're very grateful for the information that people have been sending us, but it is now mandatory for all lab staff to have the NCSP history record in front of them when reporting. So we're going to ask just some very basic questions, such as whether the person has had abnormal results in the past, but the detail about that will be already available to lab staff, so you can save us a bit of time in filling that in. Please familiarise yourself with the new consumables. HPV testing is new, and so there is some information to come about that. We're expecting that most participants will choose to have a self-test, and some may need assistance with that or would prefer to have assistance if they're not confident about doing the test correctly themselves. So you are able to assist them to take the swab sample. The NCSP will be providing practices with instructions for participants about how to physically take the vaginal swab sample, so that will be available at Go Live. Just a reminder about cytology, particularly for people who may be changing LBC type, that with thin prep, you swish the brush in the vial and then remove the brush completely, whereas with SurePath, the head of the brush is broken off in the vial and you leave the head in the container. It is possible to send the swab sample either dry or in a tube containing fixative buffer to the laboratory. Each laboratory will have specific requirements about this according to the type of test technology that they're using, and they will provide instructions for the lab that you are using. It's very important that you use the very specific swab that the laboratory asks for, because they can't process a sample taken on a different type of swab because of the validation of the laboratory equipment. It will be important for you to set up a suitable space for people to take a self-test, and just want to say a word about HPV cross-contamination, because it is possible to transfer the virus from one object to another. So please provide a rubbish bin so that any pieces of paper or tubes or plastic sleeves or anything that's left over at the end of one person's test can be put in the rubbish bin, and then the person will be instructed to wash their hands. So the risk of cross-contamination isn't high, but when women have taking their own vaginal sample from their genital area and they've got HPV, it'll be easy for them to get it on their fingers. Transporting samples to the laboratory, it's always best to get the sample to the lab as soon as practicable. The HPV swab test can be processed up to 1 month after collection at both APS and SCL. Just if any of you are listening who'll be using PathLab, if any wet swabs are sent to PathLab, there is a requirement because of the technology for these to be processed within 2 weeks, so it's a bit shorter. The samples can be kept at room temperature. It doesn't matter if you put them in the fridge, but they're fine at room temperature as well. Just avoid extreme heats, such as samples being left in a hot car, for example. HPV test results, if that's the only test being ordered, will be reported within 3 days of receipt in the lab. The turnaround time requirements for cytology are that 90% will be reported within 7 days and 100% within 10 days. And those timeframes will be the same. If you've got a combined HPV and cytology report, it'll be the 7 and 10 day timeframes for those. And just finally, a word about the laboratory results. The cytology diagnostic results are the same as they are currently. They haven't changed. The only change is that we are updating to a new international version of the Bethesda reporting system that we use. And under that update, normal endometrial cells in future will only be reported from the age of 45 years and older. The test categories for HPV testing are the same 5 that we use currently. The invalid samples are those where the sample's been processed but a result isn't possible, and this is usually due to inhibitory substances in the vial, often due to excessive blood and inflammation. So the reason for an invalid result has nothing to do with the sample taker. We have a new category of reporting called unsuitable for analysis, and these are samples that won't be processed because the sample was leaking when it arrived in the laboratory, and this is entirely within the sample taker's power to improve this because it means that the lid wasn't screwed on properly. So if a sample's leaking, we don't know that other fluid hasn't leaked into the container too. So the cross-contamination risk is too great. So no samples that are leaking will be processed. And finally, there'll be one recommendation per report. So there'll be one recommendation for every HPV report, for cytology only reports, and also one recommendation for a combined HPV and cytology report. So that ends my introduction to what's changing in laboratories, and I'll now hand over to Liz Pringle, who's the lead cytoscientist at APS.
So Liz Pringle, I'm the Scientist Unit Manager for Cytology at APS, Te Tokatū mai Tamaki Mackay. For Auckland practices currently using ThinPrep for cervical cytology, APS will provide the HPV primary screening service. So same laboratory, same team of scientists and pathologists. APS will provide the Copan flock swab for wet and dry swab collection. APS are currently only validated to process wet swabs until the laboratory has completed the dry swab validation. This means we can only accept wet swab collected samples. The laboratory will confirm with practices when the validation for dry swabs is completed. There'll be no change to the LBC cytology medium, which is we currently use ThinPrep. The primary test will be an HPV test. However, the sample can be used for further testing under the clinical practice guidelines for cervical screening in New Zealand. Request forms. It's important to indicate to the laboratory the sample that has been collected and to provide clinical information. This may influence the recall or recommendation for the patient. And Margaret's already talked about abnormal bleeding, abnormal appearance of cervix, etc. And Alicia has also mentioned that we need to know whether the patient is immunodeficient. Consumables and supplies, flock swabs and the cell collection medium for wet swab collection will be issued to referrers in the weeks leading up to the implementation date. The laboratory will provide referrers with an updated supply form with all the consumables required for HPV primary screening. ThinPrep vials will be ordered as per the current process, and future ordering of consumables / supplies will be as per the current process. It's important practices continue to monitor the ThinPrep expiry dates. We're happy to work alongside you for that. Collection of specimens. There's no change to the collection from your practice. Aotearoa couriers, better known to most of you as lab tests, will continue to collect the specimens for anatomic pathology service. So really important, and this is good practice already, but one sample per biohazard bag with the form inserted into the side pocket. The label for the LBC and the cell medium collection vials should be placed horizontal onto the vial and not adhered to the lid or the base of the vial. Flock swabs, please adhere the label vertically. Only one sample type can be processed by the laboratory for HPV testing, and that's either a vaginal swab or an LBC. When transporting the LBC or the cell collection medium, it's really important that the lid is aligned, is screwed on tight, and the markings on the lid and the vial are aligned. This will ensure that the sample is sealed correctly and will prevent leakage. As Margaret's already alluded to, the laboratory will not process samples for HPV screening when the sample has leaked. We will also not process samples for HPV screening for samples that we received prior to the 26th of July. Thank you. I will hand over to Paul Spek, scientist for SCL.
I'm Paul Spek. I'm from SCL in Dunedin, and for a number of years, SCL has been part of the APHG lab group. So we have a central cytology processing site in Dunedin for all our labs around the country, which includes the Northland and Auckland region, NPL, Northland Pathology, and lab tests. As Margaret said earlier in her talk, we are currently undergoing a rebranding. So we are now known as Aotearoa New Labs, but for the purpose of this talk, I'll still refer to us as SCL, as that process hasn't completed just yet. Now, as far as the collection devices, etc., that we use, you'll be familiar, those who use us, with the SurePath vial, so that will still remain the same for cytology samples, and also for, you can do HPV testing off it. It's really important when if you are using LBC and SurePath, that you leave the device head in the vial. And when you do that, it needs to be in the large part of the vial, in the bigger hole, not in the smaller hole. That small hole is used by our processing equipment, so it's really important that the brush head goes in that larger hole. As far as the HPV self-collect swab goes, we're using this Copan swab. It's a red top swab. It is a dry swab. Okay, so if you're currently using SurePath, that's the dry swab that you need to be using for use on our HPV testing equipment. Following collection, and there'll be advice given on how to collect those with information pamphlets. The swab has to go back into the sheath, has to be labelled, and then sent through to the lab as usual. So there's no change to the current courier collection process as far as we go. As far as request forms go, we currently have e-ordering, and a lot of practices use that rather than sending in a paper form with the sample. That's currently being updated and will be available, will be going live from the transition date of the 26th of July. So we won't put it out there until we're actually live with the new HPV testing program, and that will reflect the, it'll be the same, similar sort of drop-down menus, but will reflect the new testing. As far as the practice generated request forms go, Rachel's already mentioned that in her talk. They're currently being updated by the PMS vendors, so they should be available at some point in the future. As far as consumable ordering goes, for the lab test people, you'll be familiar with the online consumable ordering, and that is also being updated at the moment. And so this will have the self-collect swab on there as usual, and it'll be under the cytology section of that ordering form. For Northland, similar sort of ordering form. Again, it'll have it'll be updated with the HPV self-collect Copan swab. We will have these swabs available from sort of mid to late June, but we do ask that they, if you do order them sort of earlier on, that you refrain from using them until that go live date. And the important thing is that these swabs are not to be used for any other viral testing, therefore HPV only. On the cytology side of things, as you've heard from the other speakers, HPV testing can still be performed on the liquid-based cytology samples, and the cytology will be performed based on the new management guidelines. We do require cytology for test of cure, as Margaret's already said. So it's really helpful if you include test of cure, that test of cure request on your request form. It is recommended that cytology is done on symptomatic women, and we've already seen some slides on that tonight. So include all those symptoms on the form when you send it through, and these will be triaged off by lab staff on receipt in the laboratory. As far as collection goes, if you're taking a cytology sample, do so in the same way as you're doing now, the current collection devices. Really important that you don't use a self-collect swab for a cytology sample. Okay, we can't do cytology off a self-collect.
Okay, so we've got quite a few questions coming in. And thank you to the speakers who are going through and answering some of those now. A few questions coming through about the meaning of immune deficient. For example, people on prednisone, people on disease modifying drugs. Yeah, just a bit of clarification around there.
Look, I think this is one that's going to be quite tricky for primary care. There is a list of medications in the new clinical guidelines in section 3, but it's sort of as a indicative list rather than a comprehensive list. So there's good evidence in terms of people who are HIV positive, regardless of their CD4 count, and people who've had transplants being at higher risk of getting cervical cancer. There's less good evidence about the medications, but there is those DMARDs and things are on the list. So it's a bit of a tricky one in terms of a little bit of prednisone for a few days at a time, definitely not, but maybe people who are on high doses for long periods, that might be something that you want to consider. There's not a nice clear answer here, I'm afraid, which is does make things tricky for us, I think.
A few questions around if someone has not previously done smear taker training, will they need to do that in order to do this new screening?
Yes, so we need a person who is trained to sign the request form. We have to know that the person has had the right conversations with the person when they do the test, and also that they'll be able to manage the result and will know how to interpret the report when it comes through and know how to enact the next steps. So at the moment, this is restricted to current registered qualified sample takers and medical staff, but this will be, there are plans to increase training for an expanded workforce after go live.
What are some other things that could interfere with the swab validity? So we've mentioned really heavy bleeding. If someone has had, say, asymptomatic thrush, and if, kind of on that note, if the patient, for example, didn't take the swab properly, would that come back as just not detected, or would that come back as an unreliable swab?
Okay, so we are doing quite a lot of HPV testing already, as you know, as a second test after cytology. So we do have some experience with it, and the invalid rate is actually extremely low. So occasionally we do see substances in the sample, either usually from blood or inflammation, as I was saying earlier, that does interfere with the technical processing, but the rate at which that occurs is really low. The point about someone not taking the sample correctly, there is a cellular control in the test technology, so that if there are no cells at all, if somebody just waves the swab around in the air and then sends the sample off blank, then that will pick that up and that will block it and it won't be reported as not detected. But if there are enough cells in the sample, then it will give you a result. So you need to get cells from the vagina. There's quite a lot of leeway in terms of how many cells you have and how high or low in the vagina you are. But if you've got enough squamous cells, then you will get a result. But there is that cellularity control to stop people. So that if samples are sent in as a blank, then it won't give you a result.
A couple of questions about, would there be any instances where you would do an HPV swab for people under 25, for example, if they were immunocompromised or had quite a strong family history?
Yes, certainly. You'd certainly be doing HPV testing with cytology for people who are symptomatic. So quite a lot of young women do have a lot of bleeding. Sometimes it's contraceptive related or so on. So people with symptoms are certainly would be the main reason for doing tests under 25.
A couple of questions about if someone was already overdue for their smear, should they wait for the HPV testing? I think previous advice was not to, but has that changed?
Well, I think we don't want anyone to not have a smear. If they're having a smear, we're not going to ask people who come in for smears to stay away. But we're very close to go live now. You know, it's if you do have samples, for people who are having samples taken out, we haven't actually seen a fall off yet in the numbers of people who are coming through with cervical screening, but those results will be put into the current register, and then at go live, just before go live, all the results in the current register will be migrated across into the new register. So they'll all be captured and they'll all be put on an appropriate pathway in the new program. So if you have a test tomorrow and you have a normal cytology result tomorrow and there's no other reason to repeat it early, then you'll be recalled 3 years from that date for an HPV test. So there'll be people coming into the new program for the first 3 years who are having their first HPV test in the new program. It'll go on for 3 years before we work through everybody who's due for screening.
A couple of ones about funding. So for example, if a patient swab is leaking, will they need to pay for a second one? And if they got like a positive result and needed a cytology, would they have to pay for that? Is there any funding to access for people?
At the moment, this is part of the wider national cervical screening program, which is not a fully funded program. We are trying and working hard to see if we can get some funding specifically for things like follow-up, but that is not fully funded at the moment. In terms of the question about whether it's swab test or not, Margaret, any thoughts on that one, or Alicia?
Oh, look, I think you know, if I've done a test and I didn't screw the lid on properly, I would just call the patient and get them to come pick up and do another one. I wouldn't charge them for that myself, especially because you don't need to have that same consenting conversation, which is the bit that takes your time. Again, if someone's just, you know, is just if it's leaked or something, if it's a self-test. So I'd just be giving them a quick call and leaving it for them at reception to collect.
If it's a clinician collected LBC and there's enough fluid left in the vial, we can do the cytology, and the recommendation would be to recall and do a cervical swab collection.
A couple of questions coming through, maybe for Alicia here. Would you recommend using Avestin for postmenopausal women if there's a history of vaginal atrophy? And then secondary, would Avestin get in the way of the HPV test?
I'm not aware of that being a problem with the HPV test. Margaret might have, some people have found it uncomfortable to even doing the swab. So it might be useful for those people. And yeah, if people have vaginal atrophy and it's uncomfortable, then absolutely vaginal estrogen is very helpful.
I haven't heard anybody talking about this, but clearly you need to get the cells on the swab. If you've got a vagina full of cream and you put a swab into it and all you get is cream back, you're not going to get a result from that. So I think just be pragmatic about that, I think.
A few questions maybe for our lab staff. Just a bit of clarification in terms of the wet and dry swabs and what might be available where.
Okay, so I think probably for simplicity, if you're currently using SurePath, it'll be a dry swab. And so that will be available on the either lab test or Northern Pathology order form. Liz, you got a comment for APS?
Okay, so the wet swab will be collected into the flock swab will be used to take the swab, but then it'll be rinsed into a cell collection medium, and that will be the wet swab.
If I could just add, the arrangements at PathLab are going to be different again. So some people might be using SurePath at PathLab, so they'll have their own specific examples. So force comment applies to STL.
Yeah.
Will we need to swab people who have never been sexually active?
So again, it's that what does someone mean by sexually active? So if they mean penetrative vaginal sex with a male, but they've done other things, then they're still at risk of having HPV. So I guess that just is about having a sort of careful, nuanced conversation with the person about what that means to them.
Yeah, there are some people who opt to get their smear done annually at this stage. Is there an option for them to do the HPV swab annually?
We don't recommend annual smears. We don't in the current program either recommend annual testing. So, you know, it really is, it comes down to a bit of a question of a waste of resources, really. I mean, the risk, as Alicia has shown you on the graph, if you have a negative HPV result, the risk of you getting a high-grade lesion or cancer in the next 5 years is really very low. So we don't recommend that. I mean, we're not going to refuse tests that are done. There will be some circumstances where the interval between tests is important, where we may not be accepting a result, but for people who are having regular screens, I don't think there's any indication at the moment about stopping people having more frequent tests. We will be monitoring it, certainly, and I think one of the things that the program does need to think about is that with an LBC sample, the having to have a speculum taken sample is a bit of a barrier to having a lot of repeat early testing, but the vaginal swab sample is going to be very easy to take. And so I think we will, though we will worry about underscreening, we will see some overscreening. So we will, and that will be a waste of resources if that happens on a large scale. So we will be monitoring that closely. So, I mean, this is the advice at the moment, but that will be revised if we find a lot of people having screening far too frequently.
Any need to wait any period of time postpartum before doing an HPV swab?
I think the guidelines say 6 weeks, don't they, for postpartum?
You certainly need to wait for a while postpartum if you're having cytology, but I'm not aware that there's any need to wait after for a vaginal HPV test.
A couple more questions around training. So I'm not sure if Rachel, that might be the question for you. One would be, do people who've already done all their smear taker training, do they still need to do the online modules? And at the moment, I think there's a certain number of smears that people need to do every year. So will that be an ongoing requirement?
So if they've done their current training, and this isn't within their scope of practice, we would definitely want them to be doing, or encourage them to do the HPV training. The online modules are pretty straightforward to do. We'd also encourage it if it is in people's scopes of practice as well, because there's a lot of really useful information that will be in the training modules. They're not online at the moment. I did see some questions there around what was the link to them, but they will be online mid-June, and we'll send out the links when they are available for that. In terms of the minimum number, the 30, I know there has been work around this, and it's just not on the top of my head. I don't know whether Alicia might be able to rescue me here.
I think it's going to come down to 10 per year. That's just being finalised at the moment, but it's likely to be 10 cervical samples to maintain confidence.
Is there anything on the horizon to test men for HPV or people without a cervix?
No.
They are, of course, still at risk of developing HPV-related cancers, so just a bit of a push for vaccinating our young men as well.
People with abnormal smear results previously and who are on annual recalls, will they have continued annual recalls?
Well, that depends on the reason why they're on annual recall. So we've done some very careful mapping for people who are in all sorts of different clinical situations to map them through into the new program. So quite a few people who are on annual recall have had high-grade lesions in the past, and they're eligible to have a test of cure. So we'll be really encouraging them to come and have a test of cure. Now, in the current program, because we've always required consent to do an HPV test, because it does have some implications about being a sexually transmitted infection, we haven't been given the laboratories the right to add on an HPV test for the first time they have a test of cure. But in the new program, we'll be doing HPV first. So if we have an LBC sample and somebody's only ordered an HPV test and we see that they're eligible for a test of cure, we will be adding on the cytology. So we're going to try and encourage those people who are eligible for that to get back to annual recalls. Now, there is also a change in the guidelines about people who've had some categories of glandular lesions in the past will be eligible for a test of cure too. So I won't go over all the details here, but they're in the clinical practice guidelines.
Thank you. One person has said maybe the practice has been part of the research program already. How will the HPV results from the past year be recognised on the register now? That might be one for you, Rachel.
Yep, at the moment they aren't going into the register, but we can follow up with the researchers specifically around that. Separately is probably the best idea, I think.
So some of the research groups have been using validated test technology, and those results are already held on the current register, and they will be migrated into the new register. So the current register doesn't use those HPV results; it just records them. It doesn't have any implications in terms of tracking or follow-up. But once they're migrated into the new register, they'll come on board as full results.
And as Margaret said, that's for the validated tests. Yeah.
Sorry,
Courtney, sorry, Courtney. There was one question where I actually clicked the wrong button. I meant to type the answer, and this is a question around: will there be a tidy up or changes to codes used in the PMS? We'll take that back to the technical team to follow up on that one as well.
Any advice, maybe from Alicia? Any advice for women who maybe need a test of cure or need an LBC but are refusing? Let me see. There's still some benefit to just doing an HPV if that's all they want.
Yeah, look, I mean, I think that's that is something we're going to come across, and we do, right, with people who don't do what we would like them to do, and that's their right to choose that. We are missing out on information if people don't have the co-test, if it's a test in a test of cure situation. But I guess an HPV test will give us some information, but it's about having that conversation with the patient that there is risk and clinical risk involved with that. So, yeah.
Thank
Can I
you.
just make a comment about that? The research groups are finding that some people who have a primary screening test and find their HPV detected other, who should come back for a cytology result, are reluctant to do so. I just want to point out that this business about clinical risk. So if you have an HPV other on a swab, you come back in 12 months and you only have a swab again. If you're under 50, you're going to wait for another 12 months. And if you're still HPV other, you will eventually get to colposcopy. But if you had a high-grade lesion at the time of your first primary screening test and you didn't have cytology, that wouldn't be picked up. So it could take you a number of years to get to colposcopy by just having an HPV test. So that's what we mean by the clinical risk associated with just having some of the testing and not completing it. But you know, it is right. Some people will just not want to have a speculum exam for cytology. So we will make the most of whatever tests people are prepared to have.
Thank you. A couple of questions maybe for Margaret about the new register. Can women opt off of being on the register? And I'm assuming whoever orders the test is responsible for letting the person know the result. The register is not going to feed back to the person.
Everyone, there's always the right of a person to withdraw their results from the register. So the arrangement for doing so isn't changing. So you need to inform the register in writing about your desire to have your results withdrawn. And if you do so, there is, I understand, a 20-day grace period after somebody has notified them where the results are left on the register for another 20 days, because sometimes people do change their mind even if they've written in. So after 20 days, the results are deleted.
With the new register, is there any way that we as practitioners can access that and access patients' histories?
Thanks, Courtney. So that's part of the phase 2 plan from August through to December, that primary care will be able to access the information in the register and then obviously be able to do recall and everything through there. We also have, for people who don't have a PMS, we have what we're calling a provider portal, Whaihua, and that effectively provides in non-technical terms, a front door to the register, but only to the parts of the register that you'd be eligible to be able to see. And we'll be offering training on both of those, both the register and Whaihua.
Thank you. Another question actually around training. Will there be any funding available to kind of train new people, practice nurses on the HPV screen?
Great question, Courtney. At this stage, we haven't got additional funding for training. They are just online e-learning modules that we're looking at. So 4 modules, they're not particularly extensive or long. The first ones will be the longest. I think at this stage they're in development at the moment. And that's about an hour, and the others are probably more likely 20 to 30 minutes.
Okay, thank you. That was another question actually about the duration of the module, so thank you. Some comments about there's already quite a backlog in terms of getting people in for their 3-yearly screens, and the target, of course, for the amount of people that we want screened. Is the target going to stay the same? I think it's about 80% at the moment, or is that going to change?
I don't think we're changing the target. You may know that the WHO has issued a call around the world for all countries to achieve an elimination target that they've set. It's not 0, of course. You can't prevent every case of cervical cancer, but it is about 4 cases per 100,000 women. So New Zealand's one of the countries that's close, but we're not at it. So in terms of a target, that's likely to be our next goal, rather than talking about a percentage screening. It'll be a goal based on cases of invasive cancer. However, our 80% target remains for screening coverage. That's where we'd really like to be. We have seen some reduction in the percentage coverage in New Zealand in recent years. So we're really hoping that, as some of the previous speakers have said, that with the prospect of self-testing, that we can improve coverage quite significantly.
Couple of questions, Alicia, if you'll be able to speak a little bit more to Volt smears when we do those, or when we change to HPV swabbing for people without a cervix.
It's actually probably more a Margaret question, but it will depend on the clinical situation for why they had their hysterectomy.
Yeah, so there's quite a complex algorithm about this. So what we really want to make sure is that people have had past abnormalities and then have a hysterectomy are correctly followed up. So for those who have been regularly screened and have had a normal screening history, also people have had past abnormalities, but they've had enough follow-up to return to regular interval screening before their hysterectomy, such as they've had a high-grade lesion, but they've had a test of cure and they're back on regular screening, or if they've had a low-grade smear, that they've had enough cytology follow-up to get back to regular screening. So where that's the case and where there's no pathology in the hysterectomy specimen, then those people won't require any post-hysterectomy screening. But if there's any doubt about that, for example, if the screening history isn't known, even if they have a normal cervix, then we're recommending one HPV test 6 months after their hysterectomy, and to make sure that that's not detected before they cease screening. And if people have unexpected lesions in their hysterectomy specimen, if there's unexpected high-grade lesion in the cervix or unexpected low-grade lesion, then there are appropriate steps to follow those up as well. For people who haven't been returned to regular screening, such as people who might have had a high-grade lesion and they haven't completed a test of cure, then they should complete a test of cure after the hysterectomy, even if there's nothing in the hysterectomy itself. So particularly important with squamous lesions, of course, because the vaginal epithelium is squamous as well. So people have had squamous lesions in the cervix can have squamous lesions in their vagina. If you've had a glandular abnormality and the cervix has been completely removed, then of course you've really reduced your risk. So they're not at such risk post-hysterectomy.
This may be a question for Alicia, and it might be very area dependent, but where this person is, if women are referred to for a termination of pregnancy, they're required to have a smear first. Do you know if an HPV swab would suffice in place of a smear now that those are available?
I don't remember that being a requirement where I am.
No, me neither.
Okay, that's good that it's not just me. I wonder if that's more just about getting people screened who need to be screened, in which case HPV would be, but I can't speak to that specific situation in case it was something different.
Some concerns about if we're only doing an HPV swab, are we missing opportunities to assess the appearance of the cervix?
I mean, you're not going to be looking at as many cervixes, it's true. So yeah, we are not going to be looking at them, but again, I guess that's that around that. It's more around if someone develops symptoms, just how important is that you do look at someone's cervix. But yeah, you're not going to have an incidental finding of, I don't know, cervical polyp or Nabothian cysts, but are they clinically relevant anyway? Probably is not going to really make much of a difference. So yeah.
This might be one for Rachel, as it's about funding. You may have already covered this, apologies. But you're already answering that one. It's for the funding for Māori and Pacific people. Someone also mentioned Asian people as well as a group who are quite underscreened.
Yeah, so in terms of HPV testing, is it free for Māori and Pacific only? It's not free for anyone, unfortunately. What we are doing is trying to get some funding to at least try and make it fully funded for our priority populations who are Māori, Pacific, unscreened, underscreened, and follow-up. But that's a work in progress at the moment for that one. And for Asian, they're currently in the priority populations and the current criteria, but there is work ongoing with that at the moment.
Actually, if I can just step on about the Asian population. Yes. The Asian population do have low coverage. They always have had, but when we look at cancer rates, the cancer rate in the Asian population isn't high. So we can't justify pouring resources into a group that have low cancer rates. We don't really quite understand why the coverage is low and the cancer rates are low. We don't know whether it's because quite a few people in that group have a recent arrivals in the country. We do know that some Asians go back to their country of origin and have their medical services there because they can speak their native language much more readily than they can in New Zealand. So, but these are just some things that probably contribute, but we don't really quite understand why the cancer rates are low in the Asian population despite low coverage. So it's really the cancer rates that are driving the priority population. So that's why the Asians group have been now removed actually from the list of our priority groups, and now Maori Pacific unscreened and unscreened.
Thank you, that's really interesting. The new register, will that be used as kind of a recall backup for primary care, or not able to do that?
What we're working on at the moment is a notification strategy, and effectively the register becomes the fail-safe for primary care. So primary care will do their own recalls, etc. But then there's the registers there as the fail-safe. So if we haven't had a response to recall, then the register kicks in at that stage.
Would a recent HPV vaccine affect an HPV swab result at all?
No.
Great, thank you.
And yay for getting vaccinated.
Yeah. There was one other question actually about vaccines, which might be for you, Alicia. If someone with a cervix hasn't been vaccinated, would that make you want to start the HPV screening any younger, like under 25?
No, it wouldn't. No, they don't need any earlier screening. One thing I would say actually around the vaccination thing is if someone, say you've got a 25-year-old who tests positive for one of the types of HPV, there is still benefit in getting the HPV vaccination because it will cover them for the other types that they haven't been exposed to yet. So it doesn't treat a current HPV, it doesn't help them get rid of the HPV infection that they do have though.
Okay, I think we'll wrap up there because we've come to the end of our time. Thank you again to all our panel of speakers for all your presentations. I found them really informative. And again, thank you for going through and answering all of the questions that came through. So thank you so much, everyone, for joining us, and have a good rest of your night.